So as folks sign in, just a reminder to chat into the chat box your name, any credentials, where you work, and your email address. It will help us take attendance for today's call. Thank you, Lori. And if anyone has a video that they're able to use so that we can see all of your faces, that would be great. And we'll get started in just about 2 minutes. We just turned on air conditioning here in our room, so if it is too loud for people or if you hear feedback, please just let us know. And so as you're calling into, if you're able to rename yourself and do first name, last name, that just helps us know who's talking. And to do that, there are 3 little dots in the upper corner of your screen. And if you just right click on those, you can say rename and type in your name. All right, it's 3 o'clock, so we're going to go ahead and get started. For any folks who have recently joined us, if you could use the chat box to enter in your name, where you work, and your email address, that helps us with attendance and to make sure that you all have each other's contact information should you need it in the future. And if you could also rename yourself by clicking the 3 dots in the upper right-hand corner of your screen, so that it's your first name and last name. That'll also help us better know who's in the virtual room with us today. So I'm Heather Drake, a program manager at Maine Cancer Foundation, talking right now, and I'll have you all introduce yourselves in a moment. But just want to go over some quick ground rules for today's call. If you can always keep yourself muted unless you're talking, that's much appreciated. I know sometimes we can get feedback, and we'll do our best to minimize the sound in the room too. And if you are using a video camera, we highly encourage you to show your faces. And we appreciate those folks who are doing so now. Just some ground rules. Again, mute your microphone, show yourself. If you're talking about any patients, never disclose any protected health information. If you'd like to speak, there is an option to raise your hand through Zoom, or you can just, shout out, excuse me, or you can always write a message in the chat. We are monitoring the chat, so we'll be able to interject and share your thoughts with everyone too. When you're talking, please speak loudly and clearly. If there's at any point a time when you can't hear us in the room or any of the presenters, please let us know. And today's topic is on financial toxicity, so we ask that you please keep your questions and comment topic. If there's something additional, you can always chat it and we can address that in a different meeting. So before we begin with introductions, does anyone have any questions or anything else they'd like to add? We'll do introductions, then have our didactic presentation, followed by our case study and a discussion. All right, well, we will jump in with introductions then. I know this can be a little long at times, so we'll try to be speedy about it, but we do want to use the introductions as an opportunity to just continue to build community amongst each other. So we'll start with Lori Dyer in your group that you have. If you can say your name and where you work and your title too.
Hi, I'm Lori Dyer. I work at St. Mary's Center for Cancer and Blood Disorders, and I'm the oncology nurse navigator. And I have August Smith, our social worker, here with me today.
Hello, welcome to both of you.
Thank you.
Clara, would you like to go next?
Sure. My name is Clara Lambert. I work at Advocate Good Samaritan Hospital in Illinois.
No, we did not.
I'm oncology financial navigator.
I can turn this up for now, and then I can use phone too.
Oh, and just a reminder, if you're not talking, to mute yourselves. Julie, would you like to go next?
Oh, how do I get my volume on?
Hi, this is Julie Pelletier. I'm a nurse at MDI Hospital for the Cancer Patient Navigator and Palliative Care team. And we have Heather Sinclair here as well, our social worker for the Cancer Patient Navigator program.
Hello. Thank you. Welcome to you both.
Thank you.
Dorothy, would you like to go next? All right, we'll come back to you. And Michelle, you're next in my.
Right, that we are still trying to.
Hi, Michelle Hayes, Maine Health Social Worker in Midcoast Medical Group and Coastal Cancer Treatment Center in Bath.
Thank you. Angela, would you like to go next?
Katie Davids, B-O-U-R.
This is Angela Fogasato. I'm Cancer Patient Navigator and Community Health Program Manager for Healthy Acadia in Washington County.
Hello. Patricio, can you go next? And you are muted if you're trying to talk. All right, we'll come back to Patricio. Magda, do you want to go next?
Is that working?
Yes.
Okay. I'm Magda Alden, American Cancer Society Patient Navigator at Maine Med, and
I'm Tracy White. I'm a nurse navigator for melanoma and skin cancer patients for Maine Health.
Hi, welcome to you both. And we also have Karen Medeiros is with her colleagues Suzanne and Katie. They're trying to get their phone to work, and Dottie is on the line as well from St. Mary's, if I'm remembering correctly. And is there anyone else on the phone calling in that I might have missed? And we have Patricio Mansanga from Greater Portland Health as well. Thank you, Patricio. And then we'll go to folks in the room.
Hi, everyone. My name is Aisha Sheikh, and I work at Maine Cancer Foundation.
Hi, everybody. I'm Caitlin Misha. I'm a program manager also at Maine Cancer Foundation.
Thank you. And Aisha is helping facilitate our chat box today. And Caitlin is helping us with our note-taking. And it looks like we had Ellen and Melissa join us just now. If you want to say hi and introduce yourselves.
Yes, absolutely. Good afternoon, everyone. My name is Melissa Lopez-Baron, and I work here with Ellen at the Project Echo Super Hub for Oncology at MD Anderson in Houston, Texas.
Yeah, hi, Ellen Baker from MD Anderson, and Melissa and I are the Project Echo team here. Nice to meet everybody.
Yeah, thank you for calling in today. So without further ado, we'll move on to our didactic presentation. So we have Clara Lambert, who is presenting for us today, and I will kick it over to you. And just let me know. I'm happy to advance your slides, so when you're ready to go to the next one, we can move on. Okay,
thank you. So just a couple objectives. We're going to define and understand the effect of financial toxicity on a patient, look at two different health systems and their financial navigation programs, get an understanding of the patient perspective of the financial journey, and then look at where they can experience financial distress, and then how to help your financial navigation program succeed. And I included some software solutions for that. Next slide. So just to, a little bit about my personal story and how I got into this is my husband was diagnosed when we were 32 and we had 3 small kids. He was diagnosed with lymphoma, and so that's pretty life-changing. And we were young and had, you know, paycheck to paycheck kind of jobs, and so that's why I always include this picture, because my husband is just fine and he got to walk his oldest daughter down the aisle. So, but anyways, this is just, I think everybody has heard a lot about financial toxicity and how it affects so many different people. But this is a little look at it and how to take all of it into your thoughts. So most of the time when people are diagnosed with cancer, it's a surprise. And so they really might not be financially prepared. And so you have to take into effect what their finances looked like before their diagnosis. Did they have assets? Did they have debt? What was their income like? And that kind of thing. So then they get diagnosed and have to make choices. They make those choices based a lot of times on how much it's going to cost, how their insurance is covering things. All along, they are, if they're still working, they're taking time off of work. They might have a caregiver that's coming with them that's also taking time off of work. Sometimes in more rural areas, they have to travel and maybe spend a night. So there's non-medical costs in relationship to the treatment. And then there's the non-medical costs, just the cost of living, you know, rent, mortgages, groceries, gas in the car. And so all of this put together creates financial strain. And there's information about 25% some have filed for formal bankruptcy. But one of the other things is a lot of people, just the stress of finances, it can affect your health outcomes. So anyways, that is this. So next slide. So in a study done by Zafara in 2013, 42% of the patients reported a significant financial burden. And due to that burden, they chose to either partially fill a prescription, take less than they were prescribed. So if they're supposed to take it twice a day, they take it once a day, something like that. They avoided filling prescriptions. They used their savings to help pay for out-of-pocket expenses. They reduced their spending on food and clothing, and even cut back on leisure activities. And I think, you know, some people are like, oh, that's leisure. But the thing is, though, is those leisure activities are important because they give, if you're used to doing certain, you know, like going out to eat once a week, and then you can't, that's still a significant strain. And those leisure activities are normalcy. Next slide. So I've had the opportunity to work at 2 different cancer centers. This is my first. It's the largest healthcare system in northern Michigan, which is fairly rural area. The Traverse City area, I wouldn't even say is suburban, but it is the largest healthcare system up there. It takes care of a lot of outlying communities. There's 1,400 newly diagnosed cancer patients a year that go through the Cowell Family Cancer Center. Can you advance? So we started the financial navigation program there in September of 2013, and there were 2 of us that were job sharing, and looks like some of my information didn't come through on the slide, but anyways, we were able, with the number of the patients that we assisted, the increase in both the revenue to the hospital or in the savings, to grow over the next 4 years to being a 2 FTE position. And so we also, during that time, we moved from having 3 separate offices, an infusion center and radiation center, into 1 comprehensive community cancer center. So I apologize for the numbers not being on here, and I don't know them by memory anymore. So next slide. So here's some numbers. So this is what we were able to do for the program. We were able, in the first year, we helped 175 patients. It increased the revenue and saving. Either it increased our revenue or it created the savings to the facility, and those combined were $900,000. And then direct patient benefit, which we were able to put on our community needs report, was $2.2 million. And as you can see, it really, we had our first year, then we called it a portable program because we were kind of running around between the offices. And then that number looks really wrong for 2017. Oh, I'm sorry, because it was only half a year. So you can see how even just moving all into one building all together, essentially that 2017 number is going to be doubled. So next slide. And now I am working at the Brody Cancer Center. We are in Downers Grove, Illinois. The cancer center opened in 2017. We're a lot smaller. We have 10 infusion chairs and a comprehensive radiation oncology. Next slide. I think this is out of order. Can you go to the next slide? Okay, so this is just looking at the 2 different cancer centers, how they were built or put together and how they related with the other hospitals in their system. So in Michigan, we were the largest hospital in the system, and all the other ones we would work with them. By them, a lot of times more complex cases would get sent to us, and our physicians would go out and work at those other facilities. We didn't have any competition. We were just in one state, and all the physicians worked on site in our building. And now here in Illinois, we have 24 hospital systems, 24 hospitals in the system. All the other hospitals are very similar in size. We do have competition. We have a lot of other hospital systems competing, and we cross 2 states, and then the physicians have their own offices. So it's been really different to work in the 2 different ways, but it also, I think, has given me a really good perspective of the different ways that cancer centers can work. Next slide. So as a financial navigator, I've found that it's really important to cultivate relationships with everybody within the revenue cycle, because almost everything we do has something to do with the revenue cycle. So you can just see this. I'm not going to read it to you. Next slide. And so I've had to change my viewpoint because my background actually comes from working in patient accounts and being a financial counselor. And I had a pretty comprehensive understanding of the healthcare revenue cycle. But I did have an understanding of a patient's thoughts about it too. But it had been a long time. And we all work through these steps daily, so they're normal to us, but we have to stop and think, you know, when a patient calls in and they're like, I'm getting 2 bills for this, you have to stop and think, wait a minute, they're getting a bill from me, the facility, and from, say, the radiologist, and help them understand the normal. I see some, I think I see people understanding all that. So, I think it's important, you know, looking at the revenue cycle, to think about the ways that each of these different steps might affect our patients and how they interpret these different steps. Next slide. So some of the thoughts that I've had patients tell me that they have when they, a lot of times they'll get diagnosed and then they're like, wow, I have cancer. But then also a lot of times finances, they come to the forefront, usually within the first couple of days. And they want it to find the care that's going to give them the best chance to survive. And then the question is, well, will my insurance cover it? How much is it going to cost me? What's this illness going to mean to my family, emotionally, financially? Who should I tell? Will I lose my job if my employer finds out? Can I keep working? Can I pay the bills? Like, what if I have to stop working? And then what if I don't recover? Am I going to leave my family with a mountain of debt? Next slide. So this is just some of the different financial pain points for cancer patients. So let's say they do find out that they're not going to be able to work. So that throws a big wrench in the budget. If they're not working, then they have to make some decisions, like about going on COBRA and the cost of that. If they choose not to go on COBRA and maybe move to a marketplace plan, or they end up applying and receiving Medicaid, the insurance benefits change. New authorizations have to get into effect. Sometimes there can even be some issues with getting those authorizations or being an in-network provider for a patient that's already in treatment. Treatment changes, that's authorizations, different costs. And then even just getting that first bill, even if they don't have to pay the full amount of that bill, but they see that, oh my goodness, that cost $26,000 for just that one medication. And then if they lose their insurance, and also if there's any change in a caregiver's income. Next slide. So some of the reasons that patients don't access financial assistance is sometimes at the start, they don't realize that they have a financial need because they really haven't been sick very much. They don't know. They've got health insurance, it'll cover that. They don't realize what their out-of-pocket amounts are. Sometimes they're embarrassed to ask for help. A lot of times they don't know that the cancer program has resources and people that are very willing to help them with their bills. And sometimes they're afraid that if they say they can't pay, that their treatment will be interrupted or withheld. Next slide. So this just financial distress screening is really important. I think I noticed that there's a lot of social workers in the room, so you guys are probably all pretty familiar with like the NCCN distress tool. I'd also, if you are going to get copies of the slides, I would recommend go look at the cost financial distress screening. It's an interesting study that the University of Chicago has been doing. And I think patients can even go in and fill it out online. But it gives actually like a score to how financially distressed a patient is. Next slide. So this is just showing how the characteristics of people with difficulty paying medical bills, and Kaiser does a really good job of putting together all sorts of information like this. But I think that it's showing that more than half, so 58%, are people who are privately insured. So they're either getting the insurance themselves or through their employer, which is the ES. 54% is those of us who are employed. Next slide. So I think it is really important when I get started with a patient to help them understand their benefits, because once they start understanding their benefits, they understand what they're going to need help with, and it's so much easier to help them. So I recommend that you have at open enrollment, you can have like a speaker at some of your support groups or anything just to help people understand the choices that they're making about insurance. Because maybe at their employer they have 3 different choices, and maybe they can pick a different insurance if they have more education about how their health insurance will work for them. And I've become a certified application counselor with the healthcare marketplace, and that's another important thing. I think a lot of facilities have that capability. Next slide. So this is just a little picture of our spreadsheet from Munson, and just how the different things that we do to help patients and how it affected both us and our patient. And that slide that I skipped over is kind of more in relationship to this, but the different things that we do. So PAP is the prescription assistance. That's when pharmaceutical sends the medication in advance to be used specifically for a patient. The replacement programs are the replaced. Premium assistance, that facility was actually helping. We had a fund that would help patients with their insurance premiums, but also in that is included some of the foundations that do premium assistance. So that's why there is the premium expense column or row. So if we paid the premium, that was our expense. If it was paid by one of the foundations, then we did not count that in that field. Then copay assistance, which we accounted for a lot of it between the premium assistance and the copay assistance. We helped people enroll into Part D. Having just Medicare only is a significant red flag. So just working with patients and finding solutions for that. And then anything that we did to help a patient that didn't really directly affect our facility, but definitely helped the patient, we put into that community assistance. Next slide. So I think as a financial navigator, even a patient navigator, it's really important to just continuously be trying to find new things. So patient resources, network with your colleagues, reach out, network with your community. There's usually different programs in different villages and counties and cities. Get to know everybody you can, and they'll help you out. Sorry, my phone just beeped. So next slide. And then it's really important also to advocate for your patients. I think it's important to stay current on political topics pertaining to healthcare. Know and understand your facility's stand. And then when you can, take the time to call or visit your representatives and your senators and share the stories that can help them when they're making their decisions. I think some of the current topics are still oral parity, copay accumulators and copay maximizers. They need to know about all of that. Next slide. So there's 3 different software solutions out there. I've had the opportunity to pilot one, which is TaylorMed. They interface directly with our EMR. They did our benefit investigation for us. They did an estimate of how much it was going to cost the patient, and then they do real-time tracking and optimization. So they were able to tell what assistance programs were open and available, alert us if they became open. They also made suggestions for insurance optimization and gave us some really good reporting. Next slide. So over the pilot, we piloted it for 8 months. We had 244 patients. 74% of those patients received assistance, and we had $3.6 million in approved savings. And this is just a little bit about the different programs, and you can see that in this situation, there were 40% were non-medical, so that was like helping pay with, for some of those day-to-day needs. Next slide. With the pilot, we were able to be more proactive. Before that, we were catching people on the schedule. We had a lot of walk-ins, which is cool, but we were able to actually do a lot more reaching out just because it helped us organize and see who was going to need us the most. So just by having that, it really improved our productivity. We were able to assist patients with more assistance, and then it was just one of those things that just snowballed and was very good. So we had a lot better alignment. Next slide. So we concluded that using a tool is definitely improves performance, and they are enhancing their tool to add some pharmacy components and billing. Next slide. And that looks like it's the end of my presentation. So I think we're going to do the case study now.
Yes, thank you so much, Clara. And if anyone had questions related to the didactic presentation, feel free to jot them down and we'll get to questions after the case study, or we can track them too in the chat box. And has anybody new joined us? If you want to take a minute to either introduce yourself over the phone or enter your name and organization and email into the chat box. Okay. All right, we will go now to Magda, who will be doing our case study presentation, and I will bring that up for you. All right, are you ready?
Yep.
Okay, great.
I did have somebody join me, but I forgot about Manny's here. You're okay.
Hello.
But he's in the room with us. Anyway, so, Tori and Annabelle just joined from New England Cancer Specialists.
Oh, welcome.
And okay, so my case presentation is that I had a 65-year-old male who's diagnosed with head and neck cancer. He resides in southern Maine, and he was going to be going through concurrent chemoradiation treatments. Along with that, you typically do need dental extractions, which is a huge financial burden for patients, but he didn't have any teeth, so he didn't need the extractions. So kind of saved money there, in a way. But, okay, so in terms of his supports, he lived with a significant other, and I'm not quite sure, there's other people in the home as well, but I do know he at least has a significant other that is his primary support. He's retired. He does have at least a couple of family members who have joined him at different appointments, and they all do seem supportive of him, but not financially able to help him with any of his stressors. So his barriers are a significant financial barrier. He has very limited Social Security that he receives. He has no car, and nobody around him has a car in his immediate network. He's able to kind of barter with people if need be for rides. We are able to access transportation for him, and so that's been a huge help to get him to his treatments. And he's also had he's gone without medical care for a significant period of time, so there's a lot of catch up with some of his medical needs as well. So I originally became aware of him because the social worker at the primary care office reached out to me and really needed help with transportation. She has really taken on most of the needs in terms of helping him do the supplemental main care application for the Medicare savings plan, and she really got him introduced to transportation. I ended up doing the coordination for his actual appointments, like the chemo, radiation, and all of that, since I work with the offices, I know the schedules and all of that, but she was the one that got him to all of his initial appointments. And let's see, and is really she's kind of his point of contact for the most part. And he recently, because of his head and neck cancer, he did get a feeding tube placed, but really can't afford the supplies or the formula that goes along with it. And he cannot afford his prescriptions that he needs as well. So the prescriptions that he needs do not have assistance programs that are available with them. So one of them is Magic mouthwash, and the other one is his morphine pain medication. So he has had to pay out of pocket for those prescriptions, and that's been a significant burden for them. We did review with Med Access about the programs that would be available, and there was nothing for either of those. Yep, okay. So transportation's been arranged for him, so that's taking a significant burden off of them in terms of affording gas or trying to find rides in other ways. If for some reason there's been a complication with change of plans and he has to have had somebody to drive him, we have helped him by providing some gas cards that were donated to help in those kinds of situations. We did apply for a gas card assistance through the Head and Neck Cancer Alliance, I believe it's called. They sent him a really generous gift card, but it's to BP and there's none in Maine. So I told him to hang on to it and give it to somebody if he can use it for something else, but it's not quite helpful for us, so, or for him. I think I said already that the primary care social worker is helping him apply for main care and food stamps, which will fully, whenever they process that application, be helpful, but it's not helpful right now. And the Joe and Druzy Foundation would be really helpful as well, but he has no non-medical bills in his name. So like no mortgage, rent, utilities, car payments, phone bill, anything that we could apply him for. So we can't utilize that program either. And I've kind of reiterated the fact that general assistance could potentially be available if need be. But again, he doesn't really have any bills. He could potentially get some help with some of his prescriptions, but he does live in a rural community and sometimes those funds are limited. So he might not have that much access right there. Next slide. So systematic barriers is really some of our issues with Medicare. Doesn't cover what we need it to always cover. Formula feeding tube supplies is a huge issue that Medicare is not covering for him, I guess. And they're paying out of pocket. I can't remember the exact number right now, but they're paying out of pocket for some of those supplies. We do have, and I haven't explored if they might be using the NEEDS program, which I don't know if everybody's familiar with, but it's New England Enteral I don't remember what it stands for, but it's where people can donate formulas, medical formulas, and they kind of have a warehouse that they can store them in, and patients can have access to them if there's a financial barrier for them to get their medical grade formulas. So he might be utilizing that, but I can't remember. Another barrier right now is his confusion. He doesn't know who he's dealing with half the time. So he'll call the primary care social worker instead of me for transportation, or he'll call Amber, the head and neck navigator, and tell her a message that's meant for somebody else. He doesn't really quite know who's doing what, and he gets very confused with that. And then one of the biggest barriers is the fact that he entered the system directly from the primary care office versus going through our head and neck navigator. So she wasn't involved from the start. After I got involved, I involved her. So they had done direct referrals to MedOnc, ENT, or maybe, and radiation. When that's really what our head and neck navigator does. So she kind of went back through and just followed through and made sure that things were there. So some of the assessments weren't all done in the process that we tend to like them to be done in. So that was, I guess, a little bit of a struggle as well, just making sure that we closed all of our loops. And another barrier is just the fact that he's being seen at a new medical oncology practice where we're just learning different systems and approaches, and sometimes there's some barriers there that come across that some of the more established programs might not have, might have worked out the kinks in. So it's a little bit of a systematic thing there as well. Next slide, I think. So I guess my questions are, when a patient is lacking sufficient prescription coverage, I can't read the rest of that because there's faces over it. Hold on, let me move this. Ooh, hold on, I'm dragging. Okay, cool. Sorry, I like sound effects. When a patient is lacking sufficient prescription coverage or perhaps are in the Medicare donut hole, how can we help address the barrier of affording medications, particularly when certain prescriptions do not, I'm forgetting words there, I guess, do not have assistance programs? And when we can't change larger systems like Medicare, what can we do to work around these constraints and address the issues in front of us? I think that's it.
Thank you very much, Magda, for presenting. So now I'll keep the questions up, but we'd love to go to the general audience to see if anyone has feedback, and Clara as well as the presenter, if people have encountered certain situations or have any kind of solutions or recommendations for this particular case. And well, if you can't talk or prefer not to say your thoughts out loud, you can also type them into the chat box. And don't all jump up at once.
One thought I had as far as the prescription drugs is Needy Meds has a drug discount program, and you can get like a drug discount card from them. It's a discount. I don't know if it'll help though, like with morphine, so because that's usually it's a controlled substance, and sometimes these types of programs don't. But that's a thought.
Somebody just chimed in in the chat box. How about checking in with churches or community action programs for prescription assistance?
This is Angela, and United Way does help out with meds, and they have a card that you can take and present to any pharmacy, and they give you the lowest price for whatever med it is. I do have some at my office, but you can contact United Way, and they will mail you out a bunch of them.
Another question from the chat box is whether main care is an option as a secondary insurer.
Is anybody familiar with that?
Which one?
If main care would be an option as a secondary insurance to the Medicare?
Applied through the social worker with the PCP's office.
Okay.
And I believe MedAccess would, just to address some of the other questions, would have evaluated him for all, I mean, they were supposed to evaluate for all the discount programs and all of that and provide any of the information. I think that's what they're supposed to do. So I would hope that they would have done all of that when we brought it to them. But the United Way thing is definitely, I'm going to look into that for sure. And Needy Meds is like my Bible, so I did check there.
And I'll just saying about this is Manny again. Hi. So sometimes you can go online and switch out your gift cards. So that's what I was saying. Maybe if there's like, you know, a website where you can actually just switch out the gas card, like BP for yeah, like whatever.
He's going to have to show me that.
Check it out.
What are those websites specifically?
We don't know. I know they exist though. I'll have to research it, and if we figure it out, maybe we can just, you know, get those out to you guys.
It does say Head and Neck Cancer Alliance right across the front of it, so I don't know how comfortable somebody would be about switching that out. But
And did you contact the Head and Neck Cancer Alliance and see if they could swap it for a different brand?
they only have 2 brands that they do, and Amber, who does the application, who's the head and neck navigator, said that she never puts BP down, so her assumption was that they didn't have any more gas cards. For Exxon, I believe, is the only other one that they have. She's in pretty good contact with them normally, so she kind of looked into that. I don't know the exact answer to that, but I did ask her about that, and she said that she knows it's happened before when they don't have any other ones left.
And I think in Clara's presentation, she got a little bit to your second question of, and it is, you know, maybe how we can help to change larger systems is to be politically active when appropriate, and when makes most sense.
Yep, ACS cans is a great place to start. I get bonus points for that one, I think.
There is this is Angela, and there is a Medicare savings program that you can call, and if Medicare, Medicaid doesn't pay for services or medical devices and stuff, you can call them and they help negotiate with Medicare and Medicaid to get it to the lowest price possible. And I have used it. And I had one patient that had a feeding tube put in and wasn't able to actually pay for it, but it was a life-saving procedure that they had to have, and the doctor writes a note and everything, and then you go through that and it will pay for it. And it's an ongoing, like you get like approved for like a year. And you have to list what it is that you will need for supplies and stuff.
Do you know who it's through, Angela?
Pardon me?
Do you know who it's through? Because you said it's like a Medicare savings program, which would be like Maine Care's a Medicare, has the Medicare savings program.
It's like it's a QMB program, and I'm not sure what the QMB stands for.
That's part of Maine Care.
Yeah, that's through that's the extra health program.
Yeah, so he's applied for that and all that. He'll get approved for one of the levels of Maine Care, either QMB or full Maine Care based on his income. So it's just right now he doesn't have it.
Okay.
Magda, this is Aisha. I just have a question about whether there are any cancer resource centers that you're ever able to access funding from patient funds there.
So Joe Andrewsy Foundation is one of those.
Yeah.
And he doesn't have any medical bill, non-medical, they do non-medical bills.
Okay.
And you have to have it in your name, which is a barrier for some of our population. So I'm constantly calling them saying, this is my situation. I don't know what else to do to get this guy help. And I always have to come up with they're becoming very particular about how it's kind of structured and what everything looks like. No, he does not have a cell phone. So it's like mortgage, rent, utilities, cell phone, car payments, car insurance, those type of things, and none of them have that. And that's the only one that we really have access to at this point for a general population of patients. So it's not really, some, like, we have the breast cancer funds that have a lot more options, but that's very specific to that diagnosis. There's nothing. Joe and Druzy tends to be my catch-all for everybody else that doesn't have breast cancer, basically, because there's really no other funds out there. And I did see something about the Dempsey Center. They don't provide any funds, so he could go and get go to classes and get support, but they don't have any applications or funding at this point for any assistance.
Are there any other thoughts or solutions for Magda from folks? And Caitlin is also capturing all of this, so we'll be able to send out afterwards. But I'll also open it up if folks had questions about Clara's presentation that they either want to say or type in the chat box.
I just had one more suggestion. What about the Good RX prescription drug saving card? It's like up to 80% of prescription drugs. Have you ever used that?
I have used it before. I truly don't know whether or not he was screened for that or given it through MedAccess. Good RX. But so I can check with I'm going to check with MedAccess and kind of find out some of these questions, because my assumption is that they're looking at all these programs, because that's what I would be looking at if I was in that role. But I need to probably double check that I'm not just assuming things. Right?
I was going to ask if MedAccess gives you a report or anything of these are all the things that we've tried, or do they just send him, do what they can for the patient?
Oh, we got them documenting in the same medical record now, but I don't know. I can definitely ask. It kind of came through. I kind of got the update. We checked with MedAccess, and that was basically as much as I had heard about it. So, but I definitely will circle back to our MedAccess person that's in the medical oncology practice and kind of make sure that these are all the steps that she's taking when she's looking at things.
Great.
This is Aisha. I'll just add, I used to work in tandem with the MedAccess program, and I know a huge challenge is that the requirements and, let's say, income testing levels for every single different pharmaceutical company changes constantly, whether it's how often you have to apply or the federal poverty level at which you can qualify. And so, I mean, as much as I think it is possible, MedAccess utilizes software programs to help them monitor and track it, because the sheer amount of paperwork that you have to submit for every single pharmaceutical company is so overwhelming. And then communicating with patients to get them to sign it, or if their income changes or their tax returns, it's really quite overwhelming. But that all said, I'm not sure if everyone in the state of Maine is familiar with MedAccess or aware that it's available outside of Southern Maine, beyond the Maine Health system, even though they're housed within Maine Health. I don't know, like Angela, are you familiar with that in the Down East region at the MedAccess program?
Yes, we do use it here. It's one of the ones that I go to a lot.
Okay. Wonderful. I mean, I know they're always happy to help no matter where you're located.
Great. So it sounds like, just quickly summarizing the conversation, that checking in with United Way and then going back to MedAccess to see what they actually did testing for. are two kind of concrete steps that you can take next. So thank you all very much for your input and helping out on this case. Are there any other thoughts on that or questions for Clara?
This is Aisha. I have a question for Clara. One of your slides had a tracking tool on it where it noted as one of the headers that had the Navectis group listed there. Is that an organization? I know a little bit about them, but did you work with them on some of the financial tracking or use them as
Yeah, so Dan Sherman is the owner of the Navectis group, and he does on-site training for financial navigation. And that spreadsheet is the tool that he helped us, you know, as he did the training that we learned and put all of our information in.
Right.
Any other questions from folks, or we have another 7 minutes. If anyone else has maybe a case related to financial toxicity, something quick that they'd like a question answered about. I have a quiet group today.
It's Magda again. I thought of one that Tracy has that will you give the summary or no?
Sure.
Besides the advice that we both gave him? But,
yeah.
Oh, Tracy.
He's a 50-some-year-old man with a neglected basal cell carcinoma on his back who hasn't been working for at least months more. He had like infection on his face that was not very appealing, so he felt like he couldn't go on any job interviews or search for work because of the way that he looked. But now that's much better. He hasn't decided whether or not he's going to do surgery, immunotherapy, or a combination of both. But if he decides on surgery, he'll need to be out of work for several months because he'll need significant skin grafting on his mid-back. That being said, he runs out of money. He has enough money to pay his rent for July. After that, he has no money, and he's not working. I believe he's already been in touch with
our advice was to apply for SSI, to apply for general assistance through the city that he lives in, and to go out and find a temporary job until he figures out what
treatment he's actually going to pursue. Because currently, you know, I mean, when you go and you get a job and you have a vacation plan, you can say, yes, I'd really like to work for you, but I do have this plan. So kind of encouraged him to do that. But the other thing is, when he did work, he was working in like nonprofit, blah, 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 and did a lot of volunteer work. And he has got 2 refugee families living with him. So we don't even know if they're helping him pay rent, or, you know, if they're bringing additional expenses to the household. So,
but more or less it was that it's trying to help him navigate the fact that he is facing a medical crisis, but he isn't able to quite make any plans to figure out his income to prepare for himself for that. So I've suggested getting temporary jobs. It's the summertime. There's a lot of opportunities available right now. So until he knows what his plans are, if it's going to be surgery, if he has a surgery date, try to find jobs up until that point, and then he can reevaluate later on and just focus on the immediate needs of he needs to get some money to get through the next couple of months, and look at SSI and look at general assistance. But that's pretty much the only things that we could come up with for him.
Right.
And then he's not really going to qualify for any assistance programs like Joe Andruzzi at this point anyway, so I can't help him with that.
Right.
So it was more of like the financial stressor of having a crisis before we even reach a treatment phase.
Right.
Anybody have a magic wand?
That's what you need. Yeah, that's complicated, and that's the hard part. That's financial toxicity.
Yep,
exactly, and that's so frustrating because you don't know what to even say. And said at this point, his financial concerns are more important than his health concerns. And, you know, if you have somebody with a gaping, non-healing wound on their back and they say that's the least of their worries, that's pretty sad.
Yeah.
So it's a systematic thing too. We don't have any great solutions to be able to help him. But I did say that he lives in a vacation land where there's a lot of job opportunities during the summer. So that's really my only advice for him at this point was go park some cars. I don't know, do something that we could do that make some money while you can right now instead of dwelling on the larger issues at hand until you have an answer. Like try to find some approach to approach it. But there's obviously bigger issues there than what we can advise him.
Yeah, I think the hard part is that he can't qualify for anything until after he's been unemployed and has no income.
Exactly, which he's been unemployed and he has no income.
We'll be able to, the process for main care is underway, but it's the support for the other things, you know, it's the rent and the day-to-day living.
So if he has 2 other families living with him, maybe he can ask them to help out.
If they're able to work at this point.
Yeah. One's from Iran, one's, I don't even know the other country. That's just it. I don't know if they're helping or if they're adding to the financial burden of the household.
Mm-hmm. Are there any social service agencies out there? I truly have no idea. Like in the past, I've worked with Catholic Charities, if there's any kind of like behavioral health issues that go along with it, trying to cobble together like food pantries or other support services. I don't know if you feel like he has any other issues going on that he could go a different channel other than using you to access support.
I'm sure, I think he knows about most of the social service agencies in terms of the food pantries and all of that. It sounds like he's been very involved in the system, in helping others. So, but it's a good thing to be able to review with him. And I need to kind of find out if he has a PCP and maybe he can, you know, my go-to is really the PCPs at the social workers at the PCP offices sometimes for kind of helping, at least having more time and ability to sit with a patient and work out what else might be going on.
Mm-hmm.
So you can look into that.
Yeah, I think at Care Partners, they may have partnered somewhat with other behavioral health settings, working with PCPs, et cetera, where they have some programs where social workers are actually going out to patients' homes or going grocery shopping with them, et cetera. Or if it's a situation like patient has COPD and buying an air conditioner would make all the difference for them rather than a complicated medical intervention downstream that they just buy the air conditioner. So
right.
Yeah, Care Partners may be a resource.
Look at it.
All right, thank you for sharing that. I do want to be cognizant of the time as we approach 4 o'clock. So it sounds like we have some next steps for both of those cases, and many thanks for sharing them to both of you and to Clara for her presentation. We'll share the case study recommendations and the presentation via email, as well as the post-assessment that if you could all please fill out, we really appreciate it. And with that email, I will also send an attendance sheet. So if we didn't capture your name, if you can just reply back to that email when you get it tomorrow morning, that would be great. And we meet again on July 24th, and we'll continue to talk about financial toxicity. So thank you all and have a wonderful afternoon. If you have any questions, feel free to reach out via email. All right, thanks everybody.